Hi, this is Dr. Anjali here. So I'm going to cover a few questions on photosensitive disorders. Photosensitivity is a feature of Porphyria cutanea tarda, psoriasis, bullous pemphigoid, or pomphylix. So we already know psoriasis is not exactly photosensitive, though cabernerization phenomenon can occur in certain areas on UV light exposure. Bullous pemphigoid is not a photosensitive disorder, and neither is pomphylix. It's a type of endogenous eczema. So the answer is Porphyria cutanea tarda. Now, not all porphyrias affect the skin. So I'll just tell you briefly about some porphyrias. So porphyrias are disorders that occur in the pathway of the heme synthesis, right? For heme pigment in the RBCs. So there's either an enzyme deficiency or a block in the pathway, which leads to accumulation of the precursor molecules, okay, the porphyrins. They can be classified into acute and cutaneous porphyrias. I'll just talk about the two porphyrias which have cutaneous features in them. So Porphyria cutanea tarda is the most common type of porphyria, is due to uroporphyrinogen decarboxylase deficiency. So 1/3 cases can be hereditary, but certain underlying disorders, so like a liver disease, hepatitis B, C, chronic alcoholic disease, or hemochromatosis, certain medications like OCPs and hormone replacement therapy, and even renal dialysis can lead to accumulation of the precursor porphyrins. Okay. So this can secondarily cause Porphyria cutanea tarda. This is usually limited to the skin, and usually you'll have features of photosensitivity. So it's a photo for you to make it easy to remember. So you'll have skin affected on the exposed parts, the sun exposed parts. So that's the face, scalp, the neck, back of hands, and the arms. You'll have erosions, you'll have blisters, and then they'll form scabs. You may have tightening of the skin also, scleroderma-like changes. And the urine is reddish or tea colored, dark urine. Diagnosis, you can use a Woods lamp on a urine sample. There will be coral pink fluorescence. A skin biopsy will reveal subdermal blisters, and there will be a relative lack of inflammation. So that would point towards porphyria. Elevated porphyrin levels will be found in the blood, urine, and feces samples, and especially isocoproporphyrin in the feces would be elevated. Okay. The treatment of this, the first thing is sun protection, of course. Phlebotomy is recommended, so that's 0.5 liters every 2 to 4 weeks, because it reduces that iron load. Drug is HCQS that can be used to treat it, and you treat the underlying cause if it is a secondary porphyria cutanea tarda. A varigate porphyria is autosomal dominant inheritance. So mutation is in protoporphyrinogen oxidase enzyme, and there's accumulation of uro and coproporphyrin. So again, this causes photosensitivity. You will also have some neurological symptoms, and these occur in acute attacks that are triggered by certain factors. So could be drugs, could be stress, could be dieting or fasting. So again, photosensitivity is the main skin feature. There will be blistering, and that could lead to scars because these blisters are subdermal blisters. There can be increased hair growth. Okay, so that's important to remember. Other episodes, of course, of abdominal pain, vomiting, diarrhea, constipation also, seizures, quadriparesis, and even respiratory distress and electrolyte imbalance. So you diagnose during the attack. It's diagnosed by increased urinary ALA, porphobilinogen, and coproporphyrin. Histopathology again will show you the same: the subdermal blister, non-inflammatory infiltrate. Okay, and there are certain features which are easy to diagnose as a porphyria, okay, a subdermal blister. So treatment is again managing the acute attacks, avoiding the triggers, and there's an IV heme analog, which is not photosensitive. So porphyria, you know the porphyrias which are photosensitive. DLE, discoid lupus erythematosus, and SLE are both classically photosensitive, right? And lichen planus is the most obvious answer. Okay? It's not classically a photosensitive disorder. This is something you should know, drugs causing photosensitivity. So the photosensitivity can be either a very acute, like a toxic reaction. That's seen usually with things like tetracycline, especially doxycycline, can have a very acute sort of photosensitivity reaction. Certain NSAIDs as well, retinoids also. Um, Methoxylin, of course, because methoxylin is a chemical that is used in photochemotherapy. It's either given orally or topically. You apply it and then exposed to UVB or UVA radiation. So that can actually also cause photosensitivity if you overexpose. Drugs that cause an allergic reaction, that is not so acute reaction, would be sulfonylureas, quinine, and hydrochlorothiazide. A 45-year-old farmer has itchy erythematous papular lesions on the face, neck, V of chest, dorsum hands, and forearms since 3 years. So it's a photosensitive rash, right? Lesions are worse in summer, improved by 75% in winter. Most appropriate test to diagnose is. So you're talking about some sort of a photo contact allergic dermatitis, right? Or an allergic contact dermatitis exacerbated by UV radiation. So what kind of test would diagnose this best? Is it skin biopsy? IgE levels, very non-specific. Photo patch test, okay, or intradermal prick test. So the answer here is photo patch test. So a patch test is done to diagnose allergic contact dermatitis. So in a photoallergic contact dermatitis, a photo patch test would definitely be helpful. Okay, an intradermal prick test. Prick tests are usually done for food allergies, but nowadays I would say they're getting obsolete practically. So of all these answers, the photo patch test would be the most specific to diagnose a photoallergic contact dermatitis. A child with history of fever, photosensitive rash, sparing the nasolabial folds. Identify the condition. So this is a very characteristic definition. The photosensitive rash, which would typically also be called a malar rash, right? Because that's in the photosensitive area. And malar rash sparing the nasolabial fold because that is partially hidden from sunlight, okay, from direct UV radiation, is typically seen in SLE. So that would be the most appropriate answer of all these. So here are some other photosensitivity disorders just for you to see what they look like. So you have polymorphic light eruption. It's usually seen as pinpoint papules, groups of papules. They are usually hypopigmented, but they can look erythematous as well. Actinic prurigo, Hydra vacciniforme, not very common in our populations. Pellagra is a photosensitive dermatitis that is seen on the hands and feet. Here's an erythropoietic porphyria. Okay, you can see the lichenification, thickening of the skin on the hands, and is lupus erythematosus. So these are just some examples of photosensitive disorders. Which of the following UV radiation causes most skin disorders? Is it UVA, B, C, or infrared? So the answer here is UVB. Okay, UVB is the most, we'll say, clinically significant and the type of UV radiation that affects the skin the most. So among the solar radiations, okay, among the UV radiations, UVC is usually cut off in the stratosphere. Okay, UVC is from around 200 to 280 nanometers, right? Then you come to the UVB spectrum, which is 280 to 320 nanometers. Now, it is partially cut off by the ozone layer, but part of it, of course, gets transmitted. And it only penetrates up to the epidermis or so. And UVA, which is from 320 nanometers to 400, can penetrate deeper into the dermis. Okay. So UVA is important to remember. UVA is responsible for photoaging, so A for aging, and UVB is responsible for sunburn. So it's responsible for sunburn as well as skin cancers, UVB. Okay. UVA is more for photo damage and the chronic photoaging changes. A 40-year-old woman presents with a 2-year history of erythematous papulopustular lesions on the convexities of her face. There is a background of erythema and telangiectasia. The episodes are exacerbated while eating spicy food and hot drinks. So the most likely diagnosis is acne vulgaris, acne rosacea, SLE, or polymorphic light eruption. So this is quite telltale of erythematous pustular lesions on the convexities of the face. That would be the forehead, cheeks, and maybe nose and chin. Episodes of increased erythema, it says, with eating spicy food, hot drinks, middle-aged lady. So it's likely to be acne rosacea rather than anything else. So the difference between acne vulgaris and acne rosacea, this is important, is pustules, erythema, papules, or absence of comedones. The answer here is absence of comedones. That means in acne vulgaris, you classically have comedones, whereas in acne rosacea, classically, there is an absence of comedones. There will be erythema, there can be pustules and papules, of course, but there will not be any comedones. It's not primarily acne vulgaris. So rosacea, some features, of course, transient recurrent erythema or flushing, which eventually becomes persistent facial erythema. It's usually seen in the 20 plus age group. There may be telangiectasia, that is dilated and tortuous blood vessels seen on the seen underneath a thin sort of skin. There will be inflammatory papules and pustules in the papulopustular variant of rosacea. And in chronic rosacea, especially more in men, you will have phymatous changes. So that is like a fibrous thickening of the skin over the nose. You can even have over the chin and over the forehead as well. Ocular changes can be seen in 50% of patients with rosacea. So you'll have same telangiectasia, redness, and conjunctivitis, chronic keratoconjunctivitis. Just some variants of what rosacea can look like. So you can see the papulopustular variant, the erythema and telangiectasia on the convexities. Here you can see telangiectasia on the bottom on the nose, the phymatous variant, and here in the last photo you can see ocular rosacea as well.